Okay, so now I want to introduce Dr. Sullivan. He has been Mr. Question this whole seminar, and so now he gets to share one of his topics, and so I'll let him tell you a little bit more about his background, but please help me welcome Dr. Sullivan.
Thank you very much. I'm learning too, so I got to ask some questions. Like Judy said, I'm Dr. Sullivan. I'm a family medicine physician, practice out of Fremont, Nebraska. It's near Omaha. Thank you for having me. It's kind of nice to come to this pharmacy technician convention. I see us as both in the trenches. We're just on different sides of the trenches, so I like to give a perspective from a physician ambulatory side. You know, I'm that physician who you receive orders from all the time that are wrong or in wrong dose. Oh, Dr. Sullivan didn't look at the allergies, all that kind of stuff. So that is me. So what I'd like to talk about today is the importance of HIT, which is Health Information Technology, or electronic records. This has been an enormous topic in all of medicine, and I know on your side as well as my side. So I joined my health system. I was an Air Force physician, and then I got out of the Air Force and joined my current health position in 2011. That's when this topic was really kind of on the forefront of medicine, because it was a transition from paper to electronic era. So when I interviewed for the job, one of the subjects that came up was, did you use a computer in your last job? And I said, well, we did kind of, you know, I kind of implemented a system where I would do my notes on a Word document because I hated writing. I could type way faster than I could write. So I kind of did, you know, a Word document for every patient encounter and put that in the paper chart. And they're like, that's awesome. So you will become our next chief medical informatics officer for our hospital. Little did I know what that meant. I didn't even know what that position was. So CMIO's physician job that is the computer guy. I later found out I would become the most hated physician on the medical staff because I was a guy to tell all the physicians you have to use a computer. Not very popular. So that's kind of my background. So I had an interest in the computer. I didn't know anything about computers. My biggest skill was changing the background in a PowerPoint presentation. I thought I was pretty savvy, but so that's about all I knew. So my objectives today are to define what HIT is, Health Information Technology, and the purpose of why we do it in healthcare. List some workflow steps, or talk about workflow in the electronic environment to ensure accuracy, among other things, in electronic records. And then kind of go over the big picture of how individualized data entry steps are utilized across the healthcare system by many providers. So why did we even think about going electronic? So picture on the right, we all probably remember paper records. So picture of a clinic, there were rooms dedicated to storage of paper records. Hospitals had entire floors and departments associated with paper records. So as you can see, very cumbersome, very space encroaching. And on the right, you can see the very happy provider with just a pad and all the data she needs at her fingertips. and she's smiling, she's having a great day, she's all electronic. So that's kind of why we wanted to go to electronic. So, sorry. So, health information technology. Department of Health and Human Services successfully pushed the medical community to adopt health information technology. So this really didn't come from the medical community, it came from the government. The HITECH Act was passed in 2009, and I think our first group of speakers mentioned the HITECH Act. So the HITECH Act was passed by Congress in 2009, and this mandated electronic records. So whenever we get mandated to do things, feathers get ruffled. We don't like to be forced to do anything, but this was a mandate put out by the government that we must adopt electronic medical records. So what is the definition of health information technology? So the processing, the storage, and exchange of health information in an electronic environment. So that one sentence encompasses an enormous amount of things. So processing of information. So we have to have data input, we have to process that data, we have to store it, we have to have, servers that can store the massive amount of information. And a big one is exchange of health information. So it's one thing that I in my clinic have, all this data on patient information, but if that patient goes to a hospital somewhere, I have my data, that hospital might not have any data at all on that patient. And that's kind of one of the big issues nowadays with electronic records is the exchange of data for patients. So again, the HITECH Act of 2009 mandated EMRs. The second line is my opinion. Pushed by bureaucrats and politicians, not the medical community. And as a matter of fact, the initial goal, why this was done, was mainly for billing and coding efficiency. It's all about how to get paid better. So that really was the initial driving force behind physicians and health systems to go electronic, was so insurance companies can get paid better, so that they can have billing and coding more efficient. So not a great initial reason to go electronic. So up until 2009, electronic technology in medicine was very sporadically used. Those cutting edge people had a computer in their clinic, thought they were great. But the way it was used up to that time really wasn't the most efficient thing. So, for example, at my facility in 2009, we had paper charts, traditional paper charts, but we went electronic with all of our testing. So like labs and radiology reports was in a computer system. So it was kind of a hybrid model, if you will. So a typical day with a patient would be, I see that patient, I write my note, I typed it actually, so I'd write my note, then when I see that, I'd order tests on him, I'd see him back in the clinic, write another note, I would have to go to a computer, and back then, clinics didn't have a lot of computers. We probably had 3 computers in the entire clinic. which made things hard. So I had to go find a computer, log into the system, look at the look at the test results. I would take those test results and transcribe them into my paper record, and that's how business was done. So as you can see, it was very cumbersome, not very efficient at all, but we were kind of computery, so. So why not just convert everything to electronic? It sounds easy, right? The medical community, unlike the bureaucrats and politicians, we were acutely aware of what a colossal undertaking this would be. Colossal. So stuff on paper just doesn't magically get into a computer. You can't just take a picture of it, scan it in, you know. No one wanted to go through with this at all, but it had to be done in the evolution. So, how do we get that room or that floor in the hospital of paper into the computer? It's a huge undertaking. When I joined my health facility that I'm at now, we already had a computer system with data in it. And if you're in a large facility, data conversion from one system to another, let alone paper into the computer, can take years. Just you turn on the computer and you start transitioning data, it can take years, which I didn't know about. If you think about what you need to do to go from paper to a computer, you gotta have support systems. So you gotta get all the hardware. Like I said, before '09, clinics maybe had a couple computers. Now, you go to my clinic, every exam room has a computer, my office has a computer, every nurse has their own computer. If you go into a hospital, they have computers on wheels or cows. So everyone has a computer in healthcare. That hardware costs a lot of money. Software, so you gotta have a computer system. I think you guys, your patient profiles in your pharmacies is a software program. There's many different vendors or types of EMRs. These systems for facilities have a 7-figure price tag. So then you gotta hire humans to input the data, take the paper chart and start throwing in data into the computer. You had to find people who were a little bit computer savvy, but also medical, clinical. So those are the critical people to transition from paper to the computer, are people who are interested in the computer. You didn't have to know a whole lot about it, but you needed to know what you wanted the computer to do for you. So these people were really hard to find. You had to invest in IT people. These are the geeks that know how to work a computer. So your success in transitioning from paper to electronic really lied in who you had setting up the systems. Another thing why the medical community was resistant was, yes, we were mandated to go electronic, but we had to foot the bill. So your health system, hey, you have to have an EMR, and you got to pay for it too. So huge undertaking. We did not like that. So again, High-Tech Act mandated EMRs. So in '09, so when that happened, the federal government didn't send out FBI agents to see if you were electronic in 2010 and then arrest you if you didn't have one. they couldn't enforce it. But how do you enforce a government mandate? Well, with money, payment. So Medicare, to get reimbursed by Medicare for any of the services you provide, if you're a Medicare provider, you had until 2015 to get on board. Private insurance reimbursement follows suits, usually follows suits with Medicare. So basically we had, 09 was a mandate, we had about 6 years to get on board with the program. This did a couple things. One, motivated us to get electronic, because if you're like my clinic, I'm about 65% Medicare. So we either got motivated. Unfortunately, a lot of specialists stopped taking Medicare. So if you're Medicare, you had to pay cash to go to specialists. Or if you were a single provider, hey, I don't take Medicare anymore. I'm just, you either cash pay me or commercial insurance. That wasn't a very good thing for medicine at all. So unfortunately, we were a little slow on the uptake. So an article in a medical journal showed that as of 2011, so this is 2 years in, less than 20% of hospitals had an EMR. So we were dragging our feet, procrastinating, trying to figure out ways to push the date or give us more time. Another stat that came out in 2014, so 3 years later, over 75% of hospital systems had EMR. So we were slow in getting going, but it did work out finally. So again, what if I don't want to go electronic? I talked about, okay, I just won't take Medicare, and that would affect your bottom line. If you didn't go electronic, you could get fined by Medicare. So if you didn't have a system in place by 2015 and you still saw Medicare patients, you would get penalized 1% a year with a 5% rise in penalty. So if your hospital takes in $100 million, you're paying Medicare $1 million just to not have an electronic record and stay paper. So back then, think about all the providers and the nurses who, didn't even use a computer personally. These are older folks, and they were very resistant to be forced to use a computer, let alone, hey, I know how to do medicine. Why are you making me learn this computer system? It's more dangerous because I don't know what I'm doing in the computer, etc. So Medicare, again, started penalizing people after 2015. So another incentive to get on board. So the company line explanation of why we should go electronic. So the widespread use of health information technology within the healthcare industry will improve the quality of healthcare, prevent medical errors, reduce healthcare costs, increase administrative efficiencies, decrease paperwork, expand access to affordable healthcare. The only thing missing on that list is cure cancer. I mean, isn't this what we want to do in all healthcare, no matter what? I mean, I don't think going electronic is the miracle fix to healthcare at all, but these are the company line on why we should do it. So EMR versus EHR, these terms can be used interchangeable. Electronic medical record, electronic health record, they're kind of used interchangeably, but one theory is an EMR, is an individualized patient record at a certain entity, such as my clinic has an EMR. You go to a hospital, it has an EMR. You go to a cardiologist, they have their own EMR, etc. Electronic health record tends to be the overall encompassing all the patient data for an individual patient across facilities. So whether you're in the hospital, at my clinic, cardiology, the EHR can encompass several different software programs or EMRs. So real world example, so patient A comes to my clinic for care. I see the patient, I document in my own personal EMR, which is Cerner. I say, oh, you have bronchitis, here's your Tessalon Pearls, I'll order that through the pharmacy. Patient goes to the pharmacy, to you guys, picks up the Tessalon Pearls. You use a different system in your pharmacy to document that, which has been known to happen. I misdiagnose a patient, they actually have pneumonia, they get admitted to the hospital. So then they go to the hospital. That hospital, wherever they are, might have a different system, maybe Epic, for their electronic record. So there's 3 different programs for the same patient and the same encounter or the same illness. So an EHR, the goal would be to connect all of those individual entities so that we can all see everything that's going on with the patient. So, you know, when that patient gets out of the hospital and comes back to me, I'd love to know what happened to him in the hospital. So this can be an issue nowadays. So there are many systems out there. Epic, the most popular are Epic, Cerner, Allscripts, NextGen, eClinicalWorks. Interestingly, Epic and Cerner, when they started, when they were invented, they're actually invented for billing. So their focus, when they came out with all their software, was to make billing as efficient as possible. Then they're like, oh, by the way, we should probably make it useful for the physicians and providers that are seeing patients. So they kind of reverse engineered. So early iterations of these EMRs were not great for providers. They were not very user-friendly. They were great for the billing, but not great for the providers. Also, Cerner in particular, when it first came out, it was a hospital-based EMR. They didn't have an ambulatory part. Now they do, so they kind of evolved into that. eClinicalWorks was ambulatory only and didn't have a hospital software. So they got on board, and now most of these systems have both ambulatory and hospital, so that a health system can, that incorporates clinics and hospitals can use one system. That makes it nice. But again, these systems are very expensive, easily 7-figure price tags if you want to implement them. My clinic started with eClinicalWorks, and we had to transition to Cerner, and that was just as hard as going from paper to electronic. It's just as hard to go from one system to another. That's a nightmare as well, because you got to learn 2 things. So are any of these better than the others? That I get asked that all the time. I've used Epic, I've used Cerner, and I've used eClinicalWorks, and the answer is I have no idea. one system might be great at one thing, one is great at another. It's just what you learn and what you get used to. So I learned eClinicalWorks really well. And then they said, stop using it, go to Cerner. I'm like, I hate Cerner because eClinicalWorks did all this stuff. So it's what you get used to, and vice versa. So I don't know if one is better than the other. It's just what you learn. So again, connectivity. So you have all these entities. One has eClinicalWorks, another clinic has Epic, hospital has Cerner. They don't talk to each other. So they tend to not play well in the sandbox together. Think of Target calling up Walmart and saying, hey, let's collaborate and share our stuff. That'll never happen. These are billion-dollar companies, and they don't like to share their technology and the way they do things, so it's really hard to connect these systems. In addition, so for example, my health system, you got to put more systems in place to connect things. So you got to add software. Thankfully, you don't need to add hardware, but for example, things called health information exchanges were born from this. So there's a whole different entity of electronic medicine that connects all these things, and usually states do that. So in Nebraska, we have something called NEHI, the Nebraska Health Information Exchange. It's a state-run program because the state government's like, hey, at least in our state, if a patient goes from one city to another or one health system to another, we want to connect all those, so we'll put up money to fund an exchange. For me to access, so if a patient goes to the hospital in Lincoln and I'm in Omaha, I can log into a different system, which is the exchange, and see what happens. So it's a little cumbersome, but it's still better than not knowing or waiting for a fax, 100 pages of fax coming to me from that other entity. So now I'd like to talk about the electronic record itself. So you've heard the term garbage in, garbage out. So if you go from a system with none of the data put in, no input yet, your system is only as good as what you put into it. So part of the workflow of an initial system is you got to put in the data, you got to put in all the data. If you leave anything out, it's going to be detrimental down the line. So any EMR is only as good as the data you put into it. The initial trend when we were mandated to go electronic was, okay, I have an electronic record. It was, this great machine, could do a lot of things, but we didn't have time to learn it, so it became $1 million word processor. Okay, I typed in my note into the computer, that's all I need to do. So think about this, a Word document is just a document in the computer. You can't search anything, there's no discrete data. So that's what we used to do, is just put in these scan in Word documents, and it was useless. They were $1 million word processors. So it's really critical to design workflows around the technology that you have at hand. So it's critical to learn the system. It takes a lot of time. It's really difficult. So when Cerner came to town, when we went from eClinicalWorks to Cerner, all the Cerner representatives were all fancy, and they're like, hey, we're great because we're customizable. So what do you want in your EMR? And my first answer as CMIO was I don't know what I want. You tell me what I want. I've never used an EMR. I mean, it's like, how can you ask somebody that is ignorant of what an EMR can do, what they want? So, and of course, you had to pay them more money to get the information. Like, I was like, what is everybody else doing? You know, we'll do that, at least to start. And they're like, no, pay us money to get that information. So that's just how it goes. So you want the technology to work for you, not against you. So again, don't make it a glorified word processor. First thing to do is learn the capabilities of the system and then design the workflows for efficiency. So you want to work smarter, not harder. That's a great saying in the electronic world. Don't just bang your head against the wall and input data and not have it useful for you. So you want to tailor your workflows to maximize the technology. That's a key to success. So an example would be, right now, one of the things we do is patient check-ins. So we have, most electronic records have a patient portal. So a patient has access to their electronic record. So a patient in my clinic can actually log into the portal at home. They can make appointments online themselves. They don't have to call and do a whole phone tree thing. They can just find an appointment that's open and put themselves in it. They can put in their own patient data. So we hand out iPads in our lobby. So a patient comes in, they check in. Some places have kiosks where the patient can check in electronically and not have to wait in line at the front desk. So they can put in all their background data right then and there. Remember getting mailed those 10 sheets that you got to fill out before? If you don't do it, you're waiting in the lobby another 20 minutes to do it. Anyway, you can do that beforehand. So now, when my nurse brings that patient back, that stuff's already in the computer. The nurse can look at it very quickly and not have to re-interview the patient or do it themselves. So that's a good example of how making workflows more efficient. Medication reconciliation, how many know what that is? Figured you did. This is one of the biggest wins that I saw as CMIO of my facility, was MedRec. So with implementing a computerized system, we recognized, wow, we did a horrible job of MedRec, especially when a patient went into the hospital. Paper era, so the patient came in, the nurse was the one who had to do the medication reconciliation. They didn't have any access to the clinic records, so all they had was either the patient pulls out the paper list from their purse while they're laying there with it intubated, or they can call pharmacy and get, hey, what's their latest meds they're on. Very poor system. And then when they left the hospital, they were given a piece of paper with what they're supposed to be on, and it was a huge mess. Now with computerized system, we actually recognized that what we were doing was not great. So our facility decided, and I was a big driver of this as CMIO, we need to hire physician or pharmacy technicians. We hired about 5 of them to cover our inpatients. And that's all they did was when a patient was admitted, they'd go down to the ER and do the MedRec for us if they were admitted. Wonderful system there, great help, because now the nurse who is admitting that patient and has to put in an IV and get meds started and do all and put in an NG tube. Now we had a pharmacy technician doing and dedicated to the med rec, because we recognize what an important part of the event that was. So, and when pharmacy techs did it, it was accurate, it was right, it was the best way to do it. So the quality of med rec went up astronomically. When it's electronic, saves time. So when that patient gets discharged, comes to my clinic, I look up in the computer what the inpatient hospitalization did for them. I can see exactly what meds were changed, what they came off of, et cetera, et cetera. So much easier to recognize discrepancies, and it minimized duplications and drug errors. So again, back to interoperability. So I think you all know what SureScripts is. SureScripts is a system that every major EMR in the United States uses for electronic prescribing. In my opinion, SureScripts is great because everybody uses the same system from the physician office to the pharmacy. Pharmacies can receive electronic prescriptions from all systems, Epic, Cerner, eClinicalWorks, whatever, by using SureScripts. One system for everyone. That's great, in my opinion. Government didn't think so. Government said, March 2023, a federal judge said, hey, SureScripts, you're a monopoly. Because they had a 95% market share. So now the government is like encouraging many systems to be out there. So it just kind of adds to the headache. In my opinion, let them be a monopoly so it makes our life so much easier. But that's just kind of the way that goes. I don't think there's any risk that any of the other systems will become monopolies just because there's a lot of competition. You know, Epic, Cerner, kind of the forefront, but they're constantly competing. I think everybody's getting enough payment in the electronic world. So if you think about electronic records too, one big issue is cyber attacks. You've probably heard a lot about it happened at University of Nebraska Med Center. UNMC's system got hacked into. They say 1 in 4 cyber attacks are on healthcare. Is a big target, patient information, patient data. It's not just credit card stuff. But they say that the systems aren't vulnerable necessarily. The systems are secure. It's the human element that causes these cyber attacks to be successful. For example, sharing your login information, or keeping a computer open when you're going somewhere else. So it's the human element that really makes those cyber attacks successful on healthcare entities, and not the actual systems themselves. They can't, it's very difficult to hack into Cerner, but it's very easy to, get a password or something from an employee. So in summary, with the advent of health information technology, the delivery of healthcare has become more efficient, supposedly, streamlined and more detailed. It's just taken a really long time to adopt the electronic mindset, to get people on board. Again, I had several physicians in 2011, when I got the job as CMIO, told everybody, hey, we got to go electronic. A couple physicians said, I retire, I'm out. They didn't want it. They had wanted nothing to do with a computer. They're like, I've been doing medicine for 35 years and you're not gonna tell me how to, the computer tells me how to do medicine, so I'm not gonna do it, so they retire. That's fine. Errors have been minimized, enhancing patient safety. We talked about that on day one, and that's the question I asked. I was wondering if we had any data to show that, and it looks like we're just now starting to get some good safety data that yes, especially with e-prescribing. I know it's safer for me personally. You know, my handwriting might not be the best. I hate writing, I might cut corners. The computer, on the other hand, doesn't let me do that. So e-prescribing, a lot of electronic records have alerts. So if I try to order a med that the patient is allergic to, again, data input. So relying that my nurses put in the proper allergy data, if I try to order a med that the patient's allergic to, it will not let me. I can override it. I can override anything, but at least I get alerted to it, and that saves me on a daily basis, because you don't look at that stuff all the time. Dosage, are you sure you want to order this dose of this medication? Go back to the books, Dr. Sullivan, and relearn. But the computer can really work for you safely and not let you do certain things. So errors have been minimized, in my opinion. And again, it's very critical to know your own individual system. Learn the ins and outs so that you can tailor your workflows. Don't make your system a glorified word processor. Really, you want to put in discrete data so that you can search for it later. There's things like reminders. So, hey, this patient needs a CT scan in 6 months. My nurse can put that in, and then in 6 months, an alert pops up saying, hey, call patient A for their CT scan. So that's been a boon to the market. So again, critical to know your system and what it can do to maximize efficiency and get the most out of the technology. So it's been a painful evolution, but one that we had to do. The world is going electronic, so medicine has to catch up. And we can really do great things if we embrace it and learn the technology. So, all right, so that's all I had. Anybody have electronic records that they use in their pharmacy? Probably everybody does. Yeah. So, and you see e-prescriptions from all different places, right? Through SureScripts, I guess. I don't know from the pharmacy side. I just order it and it gets done. Dr. Earlmeyer.
Can you give us an idea and what it looks like when you nurse, or like you really kind of nursing staff do it and you go in and through like what it looks like as far as your med selection and your
Yep. So patient profile, or the patient record is up, and I go to a button called Orders. Click on that. And you can do a couple things. So I have a favorite folder. So I have a folder of common medications that I normally do. Augmentin, Azithro, Lipitor, etc. So click on that, and you can set up your favorites any way you want. Or you can search. So I can type in Lipitor, and it comes up with a list of all the dosage forms. And we can even go so far as to program in SIGs. So Lipitor, 1 tablet twice a day, or once a day. Azithro, a Z-Pack, painful to type in 500 day one. So we have that already loaded in, and you just click on it, hit send. You gotta choose the pharmacy. So that's one of the workflow steps we've learned. The painful way is at patient check-in, they should put in, my nurse or the front desk puts in what pharmacy they want to go to. I can change that a lot of times, and this is something I want to ask you guys. I will send an electronic prescription to Walmart pharmacy, and then right after I hit send, the patient's like, hey, can you send that to Walgreens? And I have no way of canceling the Walmart one, so I just resend it to Walgreens. What happens to the Walmart one? I never know.
So where I was previously, we would get, we would get a discontinued. So if you were to put it in and they said they want to change it, you discontinue, send them prescribing, discontinue, and then you're.
I have not seen that in my Cerner system where I can do that. I can discontinue it in my own system, like to get it off the list, and then resend it. But I don't know how to communicate that to the pharmacy. I usually will have my nurse call the pharmacy, just out of courtesy.
That would be a major problem because the patient,
Yes.
in the pharmacy, they're supposed to have 30 days restock it.
Right.
Credit insurance, but the patient needs it right away, so they go to that second pharmacy, so probably not able to get it.
Right. And that's why I will have my nurse courtesy call Walmart and say, cancel that for me. But I wish there was an automated way to do it.
Should be in Cerner, like a recall or cancel RX, because usually most of those, if they send it to one, at least our system, we use Audities for ours. It'll come up as a cancel RX to say pretty much was sent to you in error,
Mm-hmm.
so we can take it right out.
Yeah. I bet we have it, and I haven't figured it out yet. So again, use your technology rather than have my nurse manually call somebody. So I'll research that. It's been a burning question because I do it all the time.
I think, speaking on the retail, which is where I used to work, it was where the samples to different, pharmacies, and we don't have a nurse or a doctor call and say, hey, cancel it. Wherever it goes first,
Mm-hmm.
the second to go somewhere else, it comes up as a rejection. So if you send it to mine, and I fill it, and then you say, oh, patient wants it somewhere else, if it goes to that other pharmacy, the other pharmacy will tell that patient, well, hey, we filled it too soon. And then a question,
Right.
From the customer or the patient, well, this is my pharmacy here, so when the rejection comes up, because I used to work at CVS,
Right.
sometimes we have to call that pharmacy and say, hey, can you cancel it? The patient is here. So that's what happens on our.
Right. And through the electronic prescribing, I would hate to have Walmart fill it, and then they go to Walgreens and they fill it too.
Right.
I just don't know that workflow on the other end.
Right.
That's why I just have my nurse immediately call.
But then you have also some patients that forget that they switch pharmacies.
Right.
So when they come, they're asking, do you use any other pharmacy?
Mm-hmm.
And say, no.
Mhm.
I know with my experience, sometimes I would have to call the number that comes up on that rejection, and then I'll ask them, well, you
Yeah.
can use this pharmacy, and then you remember, oh, yeah,
Yeah.
I used to, fill my script.
Yep. Very nice to get it right the first, know the pharmacy and send it to the right place. Yep.
So thank you for having your nurse call that pharmacy.
Oh, you bet.
And that is such a nice courtesy, because you can just be like, oh, well.
Right,
It's not
right.
the nurse's time, and then on the other side, the technician, just like you said, you're tracking it down.
Yep.
I got a rejection, but it's a brand new script. So that's very.
Yeah, and then it causes more time for you. You call back to my office, what's going on? It just, I've evolved into that.
For that quick phone call, maybe
Yeah.
5 minutes, and there's.
Yeah,
sorry.
saves a lot of-
So,
Yeah.
I'm sure the pharmacy's in your area.
Yeah.
Rather than that phone call to anything.
Yeah. Again, Dr. Sullivan sending it to the wrong
My
pharmacy.
favorite label in the pharmacy is when the pharmacist goes, oh, never mind, I didn't fill that.
Right.
You're like, no problem.
Yeah, it's good. All right. Thank you very much.